Hello everyone. As a part of continuous cardiac education, our topic of discussion today is Basics of Esophageal Echocardiography, which will be presented by Dr. Ashish Mishra sir, who is Assistant Professor in Cardiology Department at Unmicrc Hospital and having 6 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Hello everyone. Myself Dr. Ashish Mishra, Assistant Professor, Department of Cardiology at Unmicrc Institute of Cardiology and Research Center, Ahmedabad. The topic given to me is transesophageal echocardiography for today's discussion. So the outline for discussion covers introduction, indications and contraindications, pre-procedural preparation and setup, TE probe and various controls, the various standard views comprising comprehensive TE, uses in various clinical settings, tips and trick, and conclusion. So basically, transesophageal echo uses sound waves to create high quality moving pictures of heart and its blood vessels. It involves a flexible tube or probe with a electronically steered high frequency ultrasound transducer, which is about 5 to 7 megahertz, mounted at its tip. The advantages of TE is better visualization of posterior structures, intraoperative monitoring, and acquisition of high resolution images, particularly due to absence of intervening lung or bone tissue, which leads to better signal to noise ratio, decreased image depth coupled with higher frequency transducers. Disadvantages basically are it needs special setup, technique, preparation, and instrumentation. Also, it has a learning curve which leads and expertise is required, and it is a semi-invasive procedure with associated chances of injury. The various indications as per the American Society of Echocardiography are evaluation of cardiac and aortic structure and function in situations where the findings will alter management, and transthoracic echo is non-diagnostic. So basically this involves detailed evaluation of the abnormalities in structures that are typically in the far field, such as aorta and left atrial appendage, evaluation of prosthetic heart valves, evaluation of paravalvular abscesses, particularly both native and prosthetic valves, patients on ventilators, patients with chest wall injuries, patients with body habitus preventing transthoracic echo, and morbid obesity. Second indication is intraoperative transesophageal echo, particularly all open heart, valvular and thoracic aortic surgical procedures, also used in select CABG cases with MV repair, non-cardiac surgery when patients have known or suspected cardiovascular pathology which may impact further outcomes. Guidance of catheter procedure is an evolving indication, and in fact guiding management of transcatheter based intracardiac procedures, right starting from septal puncture, ASD device closure, guiding BMV, TMVR, then maybe mitral clip device and tower are important indications, and also in critically ill patients it is one of the indication. So as per the AUC ratings given by ASC, these are the appropriate to use guideline indications, and particularly the indication which I would like to highlight here is suspected acute aortic pathology, but not limited to dissection or transection, evaluation of valvular structure and function to assess suitability for and assist in planning of an intervention, to diagnose infectoendocarditis with a moderate or high pretest probability, evaluation for cardiovascular source of embolus with no defined non-cardiac source, and also atrial fibrillation of flutter for evaluation to facilitate clinical decision making with regards to anticoagulation, cardioversion, and radiofrequency ablation. These are some of the contraindications. We should remember the absolute contraindications where in fact there is suspected perforated viscous, esophageal stricture, esophageal tumor, esophageal perforation or laceration, esophageal diverticular, or recent active upper GI bleed. Relative contraindications are history of radiation to neck and mediastinum, history of GI surgery, recent upper GI bleed, Barrett's esophagus, history of dysphagia, restriction of neck mobility, symptomatic hiatal hernia, esophageal varices, coagulopathy, thrombocytopenia, active esophagitis, and active peptic ulcer disease. So one should remember the absolute contraindication, and also in fact most of this contraindications can be ruled out based on clinical history taking. So now we come to pre-procedural preparation and setup. So one should evaluate for contraindication, evaluate for factors affecting intravenous conscious sedation risk, which are poor ability to cooperate, impaired ability to protect airway, sleep apnea, or severe critical illness, systemic illness. Then one should have the informed consent, evaluate for oropharynx for airway patency, review coagulation profile and platelet count, also have established peripheral IV line, access to suction and supplemental oxygen should be available. Patient should have ECG leads connected and monitored. Topical anesthesia, particularly 2% viscous solution or lignocaine spray can be utilized for local anesthesia. Then crash cart trolley should be available at hand side. Then NPO status should be confirmed, particularly at least 4 to 6 hours of abstinence from food and beverages is necessitated. Physicians must screen patients for medical problems that contraindicate or increase the risk of conscious sedation. Use of American Society of Anesthesiologists, particularly the physical status classification, is recommended as part of pre-procedure screening. Before the administration of sedation, one must evaluate for modified Aldred score, which is depicted below. So conscious sedation is typically defined as score of 9 to 10. Score drops below 9, it signifies over sedation. So now we come to basically the T probe and various control. So one should know the various parts of T probe to make its better utilization. So T probe handle comes with two knobs, multiplane. Basically these are the two knobs, multiplane button and the brake. And this is the basically flexible shaft with the transducer at its tip. Given this many hinge points, in fact there is an advantage that the multiplane button can be used for multiplanar imaging. Then we have the two knobs. The medial knob is utilized for anti-flexion and retroflexion. The lateral knob is utilized for lateral flexion of the probe. Then the handle itself can be clockwise or counterclockwise rotated, or maybe right to left rotated. Then also we have the transducer at the tip, which also in fact responds to the anti-flexion and retroflexion by the knobs, and there is a omniplane angle which is mediated to the multiplane angle button. So these are some of the various views which we acquire while T. Basically upper esophageal views, mid esophageal views, then there are transgastric views. So this is a schematic diagram for comprehensive T and standard views. So basically the base or the platform view is the mid esophageal 4-chamber view, from where we can acquire consecutively with the minor altercations the mid esophageal, commissural view, 2-chamber view, then the long axis view, and also by doing counterclockwise rotation the bicaval view. By altering the probe further, by withdrawing the probe, we can achieve the mid esophageal 5-chamber view, the aortic short axis view, RVOT inflow outflow view, and then also the aortic valve long axis view. Then again coming back to the mid esophageal 4-chamber view, from here in fact we should if one desires to obtain the transgastric views, then the transgastric views can be obtained in a sequence, where in fact the transgastric basal short axis view is obtained, then the short axis at the mid LV or RV, and the deep transgastric view for the apical view, and also in fact to visualize the 4-chamber and 5-chamber view of the LV. Then also in fact we can modulate the probe by various omniplane angles and acquire transgastric 2-chamber view, long axis view, and the RV inflow view. Then coming back, while withdrawing the probe, in fact we should also screen the aorta by acquiring the various standard views for aorta. These are basically the mid esophageal descending aortic short axis, mid esophageal descending aorta long axis view. Then again pulling up, basically by withdrawing we will be able to visualize the aortic arch in the long axis and the short axis view, and also one should screen for the ascending aorta in long axis and short axis view. So basically this is a schematic diagram. This provides a runway for the various views. Basically it involves the altercations by withdrawal or advancement of the shaft of the probe, by changing the multiplane angle for various views at a particular point, and also in fact by doing clockwise and counterclockwise rotation of the handle. In fact one can focus on the right and the left sided structures. So in fact now going into the detail, in fact we have the mid esophageal view, the platform view which we have is the mid esophageal view at 0 to 10 degree angles. We can see the all 4 chambers, the mitral valve and the apparatus and the tricuspid valve. So basically this is the starting view. By just slight withdrawal from this position we can achieve the 5-chamber view. By further in fact altering the omniplane angle from this platform view, we can obtain the basically the mid-esophageal mitral commissural view, where we can see the mitral wall apparatus, and also in fact we will be able to measure the gradient across the mitral valve, see the mitral wall apparatus, also the coronary sinus, and the various orientation of the scallops at the mitral annular plane. Then by further in fact changing the omniplane angle between between 80 to 100, we can achieve the mid esophageal two chamber view. Then in fact we have the mid-esophageal long axis view, which would be obtained at a transducer angle between 120 to 140, and this helps to us to see the LVOT, aortic valve, also the aortomitral junction, and basically the mitral valve apparatus. Then we have the mitral basically mid-esophageal long axis view, where we can see which can be obtained by slight withdrawal and maintaining anti-flexion, and again it will help us to see the LVOT, RVOT, and also the aortomitral angle, aortic valve and mitral valve. Then we have the screening views for ascending aorta in the long axis, where we can see the longitudinal profile of the ascending aorta, and also the short axis of the ascending aorta in the short axis. This is obtained by doing the omniplane angle at 0, and long axis is obtained by maintaining the omniplane angle or the transducer angle at 90 degree. Now again moving further, in fact we have the mid-esophageal views, particularly highlighting the right pulmonary, basically the right upper pulmonary vein, which can be deciphered here, and in fact a color flow is important while delineating the pulmonary veins. Then by further manipulation of the probe, we can achieve the mid-esophageal aortic valve short axis view, where we can see the aortic valve, we can see the NCC, we can see the LCC and the RCC. This is important to assess for the aortic valve, both native as well as prosthetic valves. We can also see the RVOT, and also we can see the pulmonary valve over here. So this is a basically RV inflow aortic valve short axis view, where we can study for the aortic valve. Further manipulation will give us the right basically the RV inflow outflow view, where in fact it can be seen that not only the tricuspid valve but also the pulmonary valve is highlighted, and we have the aortic valve in center. So in fact we can see three valves at a given point in this particular view. So this is again important when we are in fact studying for the pulmonary valve, tricuspid valve, and also for delineating the interatrial septum. Then we have mid-esophageal modified bicaval view, where we can in fact see the orientation of superior vena cava and inferior vena cava along with the interatrial septum. Going further, in fact we have the mid-esophageal bicaval view. This is again very much important when delineating the superior and superior vena cava and inferior vena cava, and also IS when we are attempting for basically assessing for the ASD device closure. Then we have upper esophageal right and left pulmonary veins view, where we can see the with a color flow, we can see the red color flow in the pulmonary veins. Then we have the mid-esophageal left atrial appendage view, which is in fact again by keeping the transducer angle at between 90 to 110, and by maintaining the mid-esophageal position and slight advancement, we can achieve the left atrial appendage. This is very well deciphered over here, the left atrial appendage, and we can see the left upper pulmonary vein draining over here. Now moving on further, in fact we have several transgastric views to explore at different angles. So at transducer angle 0, in fact we can have a transgastric LV basal short axis, LV mid short axis, and deep long axis view or the 5 chamber view on transgastric deep intubation. At 90 degree, in fact we 90 degree transducer angle, we can see transgastric 2 chamber view. At omniplane angle between 120 degree, around 120 degree, we can have transgastric long axis view and also the RV inflow view. At around 30 degree, there is a special view for tricuspid valve, which is the tricuspid short axis view, which in fact delineates all the 3 leaflets of tricuspid valve. So moving on, in fact these are the various transgastric views. We can see the basal short axis view, the opening of the mitral valve, and the arrangement of various scallops of the mitral valve and the LV. In fact even the regional valve motion abnormality can be studied in this. Then we have the transgastric mid-papillary level short axis view, again in fact delineating the LV, the various segments of LV and also the papillary muscles. Then in fact further advancement and anteflexion will lead to apical short axis view, where in fact we can see the apex of LV and RV. Particularly this is important to study the LV apical clot, or sometimes also the apical VSR. In fact further manipulation with from the prior image by doing anteflexion, we can achieve the transgastric RV basal view, which will again in fact we will be able to see the RV outflow and the pulmonary valve in this. Moving further, in fact, we have various designated views to also highlight the deep transgastric 5-chamber view with gradients across the aortic wall. So we can see the LVOT, aortic wall, and the ascending aorta, and the CW axis stands very parallel to this, and we can have the true gradients across the aortic wall in this, and also the LVOT gradient. Then we have 2-chamber transgastric view, which will be obtained by obtaining at the neutral flexion level and slight withdrawal and keeping the transducer angle at 90 degree. And in transgastric view, basically, which is the equivalent to the plaques view of the transthoracic echo. Again, we can see the left ventricle, left atrium, and the mitral valve and apparatus. Moving further, in fact, the transgastric RV inflow view, we can see the the tricuspid valve and also the RV inflow and the RA, which in fact this is again helpful in studying the tricuspid valve and its pathology. Then there is a transgastric long axis view again, which will help us to study the LVOT outflow, mitral valve, and the aortic valve. Some of the views for the aortic views, which are basically from the pullback from the transgastric and the esophageal views. So we have the descending aorta short axis view obtained at transducer angle 0. And in fact we can study descending aorta and also the accompanying hemiazygous and azygous vein. Then we have the descending aorta in the long axis view by doing the basically the transducer angle at 90 degree. We can see the longitudinal profile of the descending aorta. Moving further, in fact the upper esophageal views in fact obtained by slight again withdrawal from the base view of the prior. Then we have upper esophageal aortic arch view, where in fact we can see the aortic arch innominate vein by keeping the omniplane angle at 0 to 10 degree, and upper esophageal aortic arch view in the short axis, where we can see this the basically the at omniplane angle between 70 to 90 we can see the aortic arch, also the accompanying innominate vein. So basically these are some of the views which are in fact necessitated while doing comprehensive TE, and also in fact one can get away by doing focused TE examination. So this schematic is very important. In fact, when we want to study only the mitral valve and the aortic valve, so the mid esophageal views are apt. In fact, this should be supplemented with a good transthoracic echo. One if wants to have the LVOT gradient and also the gradient across the aortic wall, when we will need to obtain the 5-chamber view by doing transgastric intubation and obtaining the transgastric views. Also in suspected aortic pathologies, acute aortic pathologies, one should also screen for the aorta starting from the descending aorta, ascending aorta, and also the aortic arch. In some of the cases, in fact, as a stroke protocol, one should also focus on the aortic atheromas. So aortic screening is important. One should screen for the IS, one should screen for the PFO, and also in fact when there is any basically lingering vegetation or mass sitting on the aortic or the mitral leaflets. So this is the schematic of mitral valve apparatus with leaflet scallops. What we can see over here is these are the two. This is basically the 4-chamber view and the 2-chamber view. These two images can be obtained simultaneously by doing multiplanar imaging. This is an extension from T towards basically 3D T. So in fact we can see over here that the arrangement of the scallops as being the A3, A2, P2 and P1 in the 4-chamber view, and in fact in the 2-chamber view the arrangement of scallops stands as P3, A3, A2 and A1. So basically this is a very nice schematic where we can see the various scallop arrangement, and in fact the at various angulations or the transducer angle. So at the transducer basically at the mid commissural basically the commissural view we can see the arrangement of scallops between P3, A3, A2, A1 and P1. So this is important when in fact when we are dealing with mitral valve regurgitation or maybe mass attached to the mitral leaflets. In fact, it will help us to delineate the exact attachment point, and in fact it will also help the surgeons in providing the appropriate surgery, particularly in guiding them for mitral repair. Also, in fact, the mitral valve prolapse, we can see the various scallops. Many of the times the A2P2 prolapse is present. This is very well highlighted on the 3-chamber view, which is basically the long axis aortic view at angle between around 120 degree. So these are the views when in fact where we can see the various regurgitant pathologies, various mass attached over the aortic and mitral leaflets, and this will help us further in improving our care. This is the schematic for mitral valve leaflets with leaflet scallops obtained from the transgastric view. So we can see the arrangement. Basically, we have the starting from the anterolateral commissure, moving ahead A1, A2, A3, and then we have the posterior medial commissure, and we have the posterior, towards the posterior side we have the P1, P2, and P3 scallops of the posterior leaflet of mitral valve. This again depicting a typical anatomic relationship between the mitral valve and the aortic valve. We can see the A2P2 scallops of the mitral leaflet. We can see the curtain between the aortic valve and the mitral valve, and also the NCC and RCC is very much very well depicted over here. So many of the times, in fact, a precise orientation or the precise details regarding the regurgitant jet, maybe the scallops which is prolapsing, or the cusp which is prolapsing, is important, and this have to be documented in the report, and also in fact the views have to be acquired appropriately to see. This is basically the two-dimensional echocardiography planar measurements for the aortic valve annulus. So one should be very well aware that the aortic valve annulus acquired through transthoracic echo, and in fact the T can be varying, and also the gold standard currently in fact for aortic annulus measurement is basically the CT, or also now that there are growing studies which are also corroborating with the MRI studies. But also from the 3D TE point of view, we can see that in fact the longitudinal maximum separation between the two cusps is important to define the annular diameter. So basically we can see that the 2.3 centimeter is the maximum annular diameter, and it also very well corroborates with the CT findings. So this annulus finding is important in fact when we are planning a patient for transcatheter, basically aortic valve procedures or the TAVR procedures. Again, this highlights the relationship between the aortic valve and also the mitral valve with the aortic mitral curtain in between, and this is a nice pie diagram which reflects the various relationship between the mitral leaflet, mitral valve apparatus and the aortic valve apparatus with the intervening aortomitral curtain, and in fact the various scallops and the relationship between the aortic and mitral valve in the various views. Moving further, in fact, also that we should be assessing while assessing the patient for mitral valve pathology, and in fact in our country particularly where we are dealing more and more with the rheumatic heart disease, assessment of LA appendage is also important, and in fact there can be pathologies associated because LA appendage is basically 3D structure and has various morphologies. Detailed analysis at various angles, basically at 40, 60, 80, and again extending right up to 100 to 140 degrees is important, because to bring about the various morphologies of LA appendage and also its associated pathologies. So one should know that there are some echogenic structures, projections from the LA appendage. These are the pectinate muscle, and one should not in fact confuse them to the LA appendage clot. So again, in fact, this is seen, we can see in this view particularly there is a small LA appendage clot right at the apex of the LA appendage. This is a Commoden ridge, and we can see the LUPV draining right above the LA appendage. So this screening for LA appendage is also important while in fact when we are planning for BMV procedures. Also in a case where in fact we are planning for cardioversion or maybe radio frequency ablation for atrial fibrillation flutter, one should also always see for the LA appendage, because the LA appendage outflow velocities or the emptying velocities are impaired, and one can have the clot over here. So this is very much important while planning such procedures. So this is the LA appendage emptying velocity which I was discussing. So basically this is the spike, in fact the horizontal arrow which we can see. In fact usually the LA appendage velocity below 20 to 25 centimeter per second is associated with risk of stroke, formation of LA and LA appendage clot. This is very well present when there is a basically mitral pathologies, particularly severe MS or critical MS, and also in the subset of atrial fibrillation. These are the various views for the pulmonary valve. We can see the pulmonary valve view acquired in basically at the mid-esophageal level with RV inflow outflow view. We can see the pulmonary valve over here. Also, in fact, as a long axis view for the RV inflow for the outflow, and also the transgastric view. So we can see that even this pulmonary valve views are important when we are in fact now with the advent of Melody valve and pulmonary transcatheter pulmonary valve implantation. Some of these particular views are important while guiding such transcatheter procedures. This is basically a dedicated view for the tricuspid apparatus. In fact, the highlighted view, in fact, what we can see is the transgastric view, which is focusing on the short axis at the tricuspid level. It is only view in where we can see all the three leaflets of the tricuspid valve. So this is again important when we are in fact guiding transcatheter procedures for the tricuspid valve. Now with the advent of even the transcatheter tricuspid valve implantation, this some of the views are important, and one should be able, one should have expertise to attain such good transgastric views to delineate all the three leaflets, right? In fact, the anterior, posterior and the septal leaflets of the tricuspid valve. So this is going in extension again. This some of the views we have already discussed. So we can see this is the basically short axis at the aortic valve, mid-esophageal view. We can see the tricuspid valve, RVOT, pulmonary valve, and also the outflow and the PAs. Also, assessment of rims for basically the ASD, septum secundum ASD is also important, because many of the times the planning for ASD device closure or maybe surgical closure is based on the transthoracic echo as well as the transesophageal echo, and in this one should be very well versed with the various rims of the ASD, and also in fact the most important delineation for the various rims and the defect, and for the planning of septum secundum ASD, basically maybe device closure or maybe surgical closure is based on the T and also the 3D T image. This is basically the NFAS view of from the surgeon's perspective. From the RA side, we can see the large ASD 3D reconstructed images for the ASD. So we have the various rims in a ASD, like the aortic rim, we have the SVC rim, the RVPV rim. Also we can see the posterior rims between the SVC and the IVC. We have the CS rim and also the AV rim at the base. So this in fact these are acquired in the various views. Particularly to see the aortic rim, we have the short axis view at the aortic level in mid-esophageal view. Then the AV rim or the mitral rim can be seen in the 4-chamber view at transducer angle 0. For SVC IVC orientation or maybe the rims, in fact it is important to get good bicable view at the mid-esophageal level, which will bring about the SVC and IVC, and also in fact one should screen for the various draining pulmonary veins, in fact while planning for the ASD device closure. If we have the partial or complete anomalous pulmonary veins, basically the candidate would be for surgery rather than device closure. By convention definition, in fact a margin of at least 5 mm is considered to be adequate, and deficient aortic rim is present in most of the cases, but it usually does not come in way of doing ASD device closure. So these are some of the views dedicated for pulmonary veins. We can see basically the right upper and lower pulmonary veins in this view. Then again the LUPV and LLPV is depicted as basically while acquiring for the pulmonary view, pulmonary veins view. In fact, when we are planning for ASD device closure, these are the views which one should always acquire and study. In fact, and the most of the details are obtained from the spectral flow level by reducing the gain and changing the omniplane angle between around 30 degree and going for the extreme omniplane angle views at about even 124 or 130. So these are some of the dedicated views for the descending aorta. We can see the longitudinal profile of the descending aorta and also in the short axis of the descending aorta. These are some of the views for the ascending aorta which we have already discussed. In fact, the aortic arch screening is also important. In fact, this is important when we come across acute aortic pathology, particularly type A aortic dissection. Many of the times the false plane is in fact extending into the various arch vessels also, and we can see the false lumen and the true lumen. So basically the depiction over here is in short axis and also in long axis is important to delineate various the arch vessels. This is depicted very well over here. So in fact, by rotating the probe far right, we can see the innominate artery at 2 o'clock in long axis view. Then we have the left common carotid artery and also the left subclavian artery by doing various maneuvering at the basically transducer angle between 80 to 90 degree. Now moving further, we can also in fact in the short axis view at the aortic level, by slight withdrawal of the probe, we can also highlight the proximal coronaries, particularly the left main and the right coronary. These are some of the images from our clinical case done in recent past. In fact, this is a patient, in fact, a pregnant patient which presented with acute breathlessness and CLIP class 4, basically patient with pressure of systolic pressure of 80 millimeters of mercury. And what we can see, the patient had underwent basically mitral valve replacement 2 years ago, and in fact was a drug defaulter. And what we can see over here is both the leaflets of the mitral valve prosthesis are stuck, and the gradients are as high in fact as mean gradient of 28. The post thrombolysis, with after doing detailed heart team discussion and discussion with the relatives, the patient was thrombolized. Patient was intubated and thrombolized. After correcting for the INR, the INR on presentation was about 2.1, and what we have achieved is a good leaflet movement, and the gradients reduced to mean gradient about 6 millimeters of. This is again in fact a clinical case which is being assessed for BMV for severe critical MS. So what we can see is basically the doming pulmonary valve. We can also we are also able to in fact highlight the LA appendage clause, which was not appropriately visible on the trans thoracic view. So basically T can also go in a way to plan various procedures. This patient was particularly in this case patient we backed off, and in fact this patient was given anticoagulation trial and again follow up to see for the LA clot resolution. Now this is again interesting view again from a patient with severe critical MS. We can see the doming AMBL, and also we can see the various relationship between the aortic valve and the mitral valve over here. Also in fact while acquiring the transesophageal views, particularly in a stroke protocol, we should also do saline contrast study, particularly to bring out the underlying PFO. So in this patient, in fact, the saline contrast was given, and there was appearance of more than 3 saline bubbles in the left heart, which was consistent with a diagnosis of PFO, and the patient later underwent PFO device closure. These are some of the images from the text. Basically, nowadays, in fact, CT imaging is available right at the corner, and in fact, utilization of transesophageal echo, particularly for acute aortic pathology, is now diminishing. So this is a view where we can see that there is a aortic dissection type A, basically with a flap separating the false lumen and the true lumen. This is the longitudinal profile or the long axis profile for the same. So again, in fact, in a patient where CT imaging is contraindicated, may have underlying nephropathy, acute renal shutdown, and there is suspected aortic pathology, in some select cases transesophageal screening for the various aortic pathologies can be taken up. These are some of the probe malpositions which lead to injuries at various level. While introducing the probe can go into the piriform fossa. In fact, it can go very well into the laryngopharynx, or it may be even get captured in the oropharynx due to acute antiflexion of the probe. So one should be aware when the probe is not advancing, one should check for this probe malpositions. Also, while acquiring the deep transgastric views, in fact, the critical junction is the gastroesophageal junctions, and many of the times if inappropriate manipulations are done, this junction can get severed. One can have upper GI bleed due to the injuries at the gastroesophageal junction. So one should be very well acquainted and careful and cautious while doing gastric probe manipulations, particularly when crossing the gastroesophageal junction, and doing extreme antiflexion when acquiring for the various views from the fundus level. These are the potential sites of injury. Basically, at the oral level, we can have dental or lip trauma. That at the oropharyngeal level, we can have laceration or perforation due to malpositions or excessive basically pressure or advancement, inappropriate advancement technique. Then at the esophageal level, again we can have laceration, perforation, or situations where we can have upper GI bleed during the procedure. Also, if the probe gets malposed at the laryngeal level, we can have vocal cord trauma, airway compression, and also accidental tracheal intubation, where patient can have acute decompensation. At the gastric level, we have already discussed there can be laceration, perforation, and bleeding while negotiating the probe through gastroesophageal junction. These are some of the list of complications which are in fact reported in the AAC literature, and in fact we can see the overall complication stands very low, in fact as low as 0.18 to 2.8%, and for intraoperative it is very less, about 0.2%. And most of the complication which we should be aware of is the esophageal perforation. Some patients may have heart failure, arrhythmia, tracheal intubation, endotracheal tube malposition. Then we may have laryngospasm, bronchospasm, dysphagia. Also we can encounter pharyngeal bleeding, severe odynophagia post procedure, hoarseness, or maybe lip injury or dental injury. So some of these complications, in fact one should be with a gentle and a cautious manipulation of the probe. Most of the complications can be avoided. So coming winding up our talk, basically some of the safety and the checks in the transesophageal examination. So after the comprehensive TE examination is done, we should proceed to remove the probe. Make sure the probe is in neutral position before attempting to remove it. Check immediately post procedure vital signs. Well, one should clear the mouth and airway secretions. Also check for bleeding from the mouth and also blood on the TE probe if any. Check patient mental status and degree of conscious sedation if conscious sedation is used for basically comprehensive TE. Also one should check for neck pain and difficulty in swallowing if at all while if there was malposition while advancing the probe. So some of the tips and tricks in order to remain spatially oriented, it is best to undertake this manipulations at a greater image sector depth so as to have more landmarks to guide our intervention and imaging. The mid-esophageal 4-chamber view is the easiest to obtain and recognize as so much to use to orient the operator. If you get lost basically during a study, return to this view and start again. So basically the concluding remarks, transesophageal echo represents a valuable and generally safe diagnostic and monitoring tool for the evaluation of cardiac performance and structural heart disease, and can favorably influence clinical decision making. Although complications associated with TE probe placement and manipulation can occur, these events are rare. Awareness of the possible complication, proper identification, careful assessment of patient is very important. Thank you.